The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Got an important topic to discuss today. We're talking about death and dying and how we deal with that as healthcare people and as human beings and how that affects us. I'm talking with a former coworker, Justin Gallien. Justin is an oncology nurse up at Tristar Centennial Hospital in Nashville. He and I worked together a long time ago when we were paramedics. He's been listening to the podcast and he reached out and expressed some interest in talking about this topic, so we got it put together for you. This is probably not something that a lot of us really enjoy talking about or thinking about, but obviously it's a big part of life, a big part of medical care. Whether you're dealing with people at the end of their lives or not, obviously death's inevitable, and a lot of times that makes its way into conversations that we have with patients and with each other. So it's sort of like the elephant in the room. It's always there, it's always present, even if we choose not to acknowledge it or talk about it. I noticed even during our conversation that I was kind of pulling us away from the topic that we were there to talk about. I kept having to sort of get us back on track because I had asked some question that was not even relevant. And I've noticed too in the weeks since we spoke, I've been dragging around about getting the editing done and finishing it. Maybe there's some subconscious avoidance going on there. Maybe I need to speak to my therapist about that. But it is just a hard thing to talk about. I lost it in the middle of the recording, started boohooing while we were talking. I cut that out so you won't hear it. But it really is a hard thing to talk about. But at the same time, as healthcare people, discussions about death or especially dealing with people at the end of their lives, that's a time when we can really make an important difference and really leave a lasting impression on someone. And that was one of Justin's main points that we focus on. I'll throw a trigger warning out there just because of the subject matter we are discussing, but there's nothing in here that's especially gruesome or disturbing other than just discussions about death. And we each tell some stories, but nothing graphic or vulgar. I guess the trigger warning is just for sadness. I think you'll be able to hear the sadness in both of our voices at different times as we're talking about this. So anyway, here I am stalling some more. Please enjoy my conversation with Justin Gallien. All right, Justin Gallien, welcome to Knowledgeable Provider. I've been looking forward to this, man. Thanks for doing it.
Absolutely. Glad to be here.
Yeah, awesome. You want to introduce yourself? Tell us your background and bio and whatnot?
I've been in a form of healthcare for about 25 years now, kind of like you. Started young age in the volunteer services, 15 years old, volunteer fire department.
15?
15,
wow.
Yeah. Started actually able to go on calls 16 when I could drive.
That's helpful, yeah.
Yeah, it easier to get around that way. And then eventually got my EMT license, paramedic, worked on the ambulance until I got exhausted of it and went and got my RN license and still working as an RN today. Seen a little of every different aspect of everything, I feel like, especially during the COVID era.
I bet, yeah. Where were you during COVID?
Hella Keller in Sheffield, so
okay.
A little community hospital that was, well, nobody was prepared for what we were about to go through, but a small community, no way we could be prepared. A lot of growing pains, a lot of learning during that time, I would say.
What unit were you working in during that?
The quote-unquote makeshift COVID unit that we just kind of had to throw together. It was pretty brutal at first. I remember we had turned 2 of our palliative care rooms that, had the family room adjacent to it, where you could keep 2 ventilated patients and a nurse just stepping in between rooms at the same time. It was horrible. Eventually, we turned our old dialysis unit into a 6-bed COVID ICU where you could actually see inside the glass doors, not necessarily have to be dressed out with them at all times. That was a lot more convenient, but it was a rough time in healthcare for everybody involved, and very applicable to today's topic.
I feel pretty fortunate that I just happened to get out of the hospital right before COVID happened.
Yes, good timing on your part.
Yeah, and part of me actually felt guilty during that. I'm like, man, I should go back and help. I tried to do my part by keeping people out of the hospital.
True,
but it was definitely not the same as working in a place like that. For sure.
Very exhausting, I would say.
Yeah. So you and I worked together as paramedics at North Star in Florence.
Yes.
In the early aughts.
Many moons ago.
That's been a long time ago. You got in touch with me, and I appreciate that. I love it when people get in touch and have something that they want to talk about. That's really cool. Your pitch was that you even had a title, Don't Take It Home With You, with the don't crossed out. I'm going to try to format the episode title that way if I can. You want to talk about that? Where'd you come up with that, and what's that mean to you?
When I was thinking of things that we could possibly talk about, I just kind of went to things that I feel like are not spoke of the way they should be. And death and dying, which we'll get a little more into, I feel like it's one of the biggest things that is just kind of pushed to the side. People don't want to talk about it. But the don't take it home with you, I think everybody new to healthcare has heard that at one point when they're getting advice from someone that's training them or whatever. I used to tell it to people myself, but I've learned through the years, there's no way to sugarcoat it. That is the biggest load of bullshit that there ever could be. There's no way you can go through these highly emotional, traumatic events and not feel the emotions. So trying to stuff that down and suppress those emotions and not, quote, take it home with you is impossible. And it's actually harmful to us as providers. I know everybody's probably heard the don't take it home with you. Let's scratch the don't out. Feel okay to take it home with you. Feel okay to feel those emotions. Because if you don't, you're going to suffer from it yourself.
I love that. I think that's perfect advice. And yes, that is what we should be telling people new to healthcare and telling each other.
Yeah.
I feel like maybe it's easier when you're younger to kind of do that, to kind of push it down. And
right.
I know as I have gotten older, that's not an option anymore. I got to deal with the emotions. I got to work through it.
Absolutely. Yeah. If you don't, eventually it will catch up with you. And it makes us not only not as optimal as a person, but as the provider. You're clouded. You're just not doing as well as you can. So we've got to all just feel our emotions. They're telling you something. I'm not a therapist or anything, but we've got to take care of ourselves adequately before we can take care of other people.
Do you want to talk about kind of your experiences over the years that kind of led you to this point?
Sure. I think coming from pre-hospital to in-hospital, personal experiences involved as well. I've seen about every scenario with death and dying that is possible, or at least I hope so.
Yeah.
From rolling up on a horrific scene of a car wreck, someone you do not know, and they're dead, to taking care of somebody for a very long time, getting to know them, getting to know their family, and watching them deteriorate. All of this is traumatic to us as providers. All of it has its effect on us. But some would say it might be a little bit easier to deal with someone you don't know in an acute event, that basically you let the next person come and get them and you're on your way. But that's not necessarily the case. Everybody handles every situation differently. And thinking back over my career, there's no way I could remember every call I've ever ran, every patient I've ever encountered. Nobody can. But I find the ones that just pop back into memory sometimes a little odd and random. And some have been, just like I said, just a random traumatic death that perhaps the family, the way they reacted, kind of stuck with me a little bit.
Yeah, that's huge.
And then, of course, people you know, people you've got to know, you're on a first-name basis with them, you're taking care of them for extended periods of time. That's definitely going to hit hard. But sometimes you just don't carry it as much as you do others. So I think it's just different how our minds and everything conceive a situation. But that's where it's important to listen to your emotions and see what they're saying to you. Because if they're telling you, go to the stairwell and have a little crying episode, go do it. It's okay. There's nothing wrong with that. Sometimes it's okay to wait till you're off shift, off work, and just go deal with it however, preferably a healthy coping mechanism, but read your emotions and learn to. And that's something that's not easy to do. It takes a lot of practice and a lot of, being mindful. But the more you learn to do it, the easier your life's going to be, especially when these situations come through.
It's weird that there still is a stigma about mental health care and going to therapy and taking medicine. And
oh, yeah.
I hear that a lot with my patients. And I spend all day going, I take antidepressants. I go to counseling. I love it. You should try it.
Absolutely. And that's a different podcast all in itself because, the mental health in this country especially is a joke where it probably should be one of the biggest priorities we have.
You want to talk about healthy coping mechanisms or unhealthy coping mechanisms? What are some things that you have some experience with?
So, there's always I don't want to say cliche, but, some of the most common things you hear, some deep breathing, being mindful, therapeutic ways to cope with things. Are they effective? Yeah, they absolutely are. But sometimes it's not enough, of course. So learning whatever works for you is going to be everybody's little personal journey. Maybe some people like to journal and find that very therapeutic. I despise it myself. I just can't. Venting to someone in a private setting, of course, that has a like mind of yours, that's okay. Sometimes just getting those feelings out is healthy. Clearly, unhealthy would be going out and getting wasted every time that you have a rough day or whatever, or using drugs, things like that. But I think one of the most unhealthy coping mechanisms that's probably not spoke about is just suppressing everything.
Yeah.
Shoving it down to eat. I'll worry about it later. That's just waiting for the explosion when it's not appropriate to explode. Because I feel like there is justified anger and there is not justified anger. So we should try to keep our anger to the justified levels. Someone comes at you with a gun and points it in your face, I think that's appropriate to be angry and defend yourself. Just because a patient has called out for the third time wanting ice water in 15 minutes, you don't need to go off on them because you're having a bad day. You can feel annoyed, but you don't take it out on them. There's many different ways, and I just encourage people to take care of their mental health. There is a stigma around it where there shouldn't be, but I'm hoping that we're, slowly making progress to getting rid of that stigma, because so often we hear people taking their lives because they don't know how else to cope. And it should never get to that point, but unfortunately it still does. I would hate to see that happen when it's always preventable.
I'm sure everybody in healthcare, I know I personally have run into people that you can tell it's just kind of ruined them. They're just mad all the time. It doesn't matter the situation. They're always bitching. They're always mad. They're like, nothing's ever okay.
Oh, yeah.
It's easy to fall into that, especially when you're with somebody like that on a truck for 12 or 24 hours.
Yeah.
It's real hard to stay positive. I can fall into that too, but sometimes it makes me sad when I see people like that. Like, what happened to you? What happened to your brain?
And I just encourage people, if you're in healthcare and you're that bitter person, take a step back. Maybe it's not for you. And it's not for everybody, and that's okay. Find a different career. You can always change careers.
Sure.
You have every option available. But if you really do believe it's for you, find a way to not be that calloused old, people that just when they know you're coming into the presence of the room, cringe.
Yeah.
That's not good for anybody.
So you're currently working in oncology, yeah?
Yes.
That's a lot of death and dying.
Yes.
I mean, I would imagine.
Yes. Big wins, big losses, I would say. Happened into that job by total accident, but have found out that's like truly my calling. Really enjoy it, but it comes at a price. Because now, on the ambulance, like I said, most of these times, when you saw death, it was usually acute, abrupt, people you didn't know. And that's not the case here. You know these people's families, you know them, you know what their favorite colors are. I mean, you know everything about them. And that makes it very tough, especially if over the course of a long time, they've improved, treatment's working, and then it goes south again. And then you just ultimately realize there's no good end in sight here. We just have to make comfort the priority. And that's tough on us as a provider. So I've really had to humble myself, I think, a lot in this. I've learned that there's no shame when you know it's the last time you're going to talk to somebody that you've cared for, to have the moment with them. You're not surprising them at all. They know they're dying. They know that their time's limited. Say what you need to say. Cry it out with them. Hug them. Do what you need to do. Do whatever's appropriate, that they feel is appropriate, of course. But you've got to get your closure in it, too. But you're also hopefully giving them closure, because you've been a big part of their lives. Sometimes I think we're a bigger part of people's lives than we ever realize we are. So it's always very important to just be honest and open, I think, in everything. But in this situation, I think it's even more important.
Yeah, that sounds like great advice. I guess I don't have a ton of experience. I've never worked in oncology or somewhere really where people were dying frequently, I guess. Pediatric ICU, that's probably where I learned more about grieving and being with the families when somebody's dying. And it's impossible not to cry and show emotion when it's a child involved.
Oh, of course, yes.
I don't think I ever learned about that on the ambulance, Because like you said, it's people you don't know, and it's bad enough, but it's not the same. We're sitting in my office currently at my little primary care clinic. What you said a minute ago about how big a part of people's lives you are, a lot of what I do here just feels so podunk and piddly compared to, I mean, I feel like I used to save lives, I used to restart hearts, and now I'm like, yeah, let me look at your feet,
Yeah.
But I really have been surprised at how grateful people are and the relationship that you kind of develop over time. And yes, it is a lot harder when patients die here.
Mm-hmm.
There's a pile of charts. I know exactly where it is in this office of all the deceased patients, and I hate walking by that pile of charts.
Understandable.
I'm like, move that downstairs.
Yeah, I mean, it's the little things that you just do as part of your day. You don't even think about after you do them, but that could have been huge to someone. So I think that's another thing to just be mindful in your everyday things you do. Taking an extra 5 minutes when you don't have that extra 5 minutes in reality, just to do something for someone, that could change their life. And it could be something as simple as getting them an extra pillow or just talking to them. Anything like that, they're going to remember, because anywhere in healthcare, you're dealing with someone at the worst stage of their life and they're scared. And it may be routine for us. We may see this every day, but it's not for them. Especially in an oncology setting, they've just got the worst possible news they could ever get. And we do a lot of re-education. They've been educated on everything they're going through. But when you just received a devastating diagnosis, you can't retain all this brand new information. And I found myself day after day after day, something as simple as just re-educating why you're taking this medication every single day. Have to remind them. But they just cannot retain the simple things because their mind's so fixated on the big picture. So even little things like that, the right thing to do is just, okay, you're taking this for XYZ. And just repeat it every day, reassure them, instead of, I told you this yesterday, are you not listening to me? That's going to make the difference in how you are remembered as a provider to them. And some people you could do everything in the world for, and they're still going to hate you. They're just those type of people.
Yep.
Don't live to please people, because you will fail, especially if you're trying to make everybody happy. But do everything right, so when you're wrong, it's just in their eyes, and there was nothing you could do about it. We're all still human. We're still going to make mistakes, but we'll just try to be mindful of everything we do to be the best we can. And I think if we're keeping ourselves in check and our mental health in check, that's going to help us do that.
We think about caring for patients. Can you talk about caring for the family members as well, and how to kind of balance that?
I have kind of adapted the idea of getting away from the term patient. I think it's almost impossible to not utilize that term, but to at least have the mindset of they're not a patient, they're not a room number, they're not a name on a chart. They are a person that has a story, that has feelings, that has everything. And so are the families. They're a big part of this. So actively getting them involved in the care is the best thing you could do. The patient always does come first, and what their preference is, make sure you're mindful of that. If they don't want the family to be as involved or active in it, then, cordially find a way to do so. But most people, if their families are there with them, that's because they want them there and they want them to know everything. So just remembering something as simple of, okay, I'm going to bring you some more water. Hey, Mr. Jones' wife, do you need some water too? Can I get you anything? Something simple as that can go a long way. And then just keeping them informed, especially if the patient is not doing well and potentially confused or whatever, not able to communicate to them as they usually do. Keeping the family updated about what's going on and what we're doing, and just providing them reassurance and just being that kind person. A box of tissues may be all that makes or breaks you in their image, but it could also make a big difference in what's going on. So just always keep in mind to read the room, and I'm probably going to say that about 10 times throughout this, but read the room and see what needs to be done. Different cultures, different beliefs may have different ways of handling things, and we need to be sensitive to that. We have a job to do. We have, what's within our scope and what we should do, but outside of that, we need to be taking care of everybody that's in the room.
Love that. This may not be where you were going with that, but when you said that, what it triggered in my head was thinking like, When you're younger, when you're newer in healthcare, you kind of, especially if you work for a big organization, a lot of times I'll speak for myself. A lot of times I would tend to default to like policy.
Mm-hmm.
Almost always going against what your human reaction would be. And this is the rule. This is the policy. But I think as we get older, as we go on in our careers, I hope we transition more into like, this is what feels right at the moment. Reading the room.
Right.
That may not be what you meant at all, but that's what it felt like to me.
Definitely one aspect of it. Yeah, absolutely. I think to some degree, everybody that, whether you're a paramedic or a nurse or whatever you're doing, you get that new license, the ink's not dry on it. You're full of piss and vinegar, ready to save the world.
Uh-huh.
You're just going to save everybody. Newsflash, spoiler alert, you're not.
Yeah.
And that's not what you're here to do. 90% of the EMS calls I ran in my career was not life-saving, miracle ALS calls.
Yeah. Absolutely
not. When you come out of school, you think it's all just going to be like TV. TV has killed healthcare.
Okay.
The media portrays healthcare as this sensation that it is not. Unless, I guess, you work in some kind of major city in an emergency department or intensive care or something like that, then you're probably a little more active in the life-saving, probably constantly than, what most people would be. But most of the time, we're dealing with very minute things. But it doesn't mean that it's not important in the grand scheme of things. So, yeah, if you're new to healthcare, sorry to tell you, it's not going to always be exciting and the adrenaline rush, but that's not what it's about anyway.
I've grown out of the adrenaline rush phase. Like, I've had all the adrenaline I need.
Yeah, same here.
Yeah.
Even now, a bad alarm will go off. Someone's trying to get out of bed. Younger nurses are running to the room. I'm not running.
Yeah.
Number one, if I get the broke hip on the way to the room, I'm not going to do anybody any good. But, I just can't handle that adrenaline rush anymore.
Yeah.
No, I'm not even going to say I'd take my time getting there or anything. But, the running just don't happen. It's something as I'm teaching, ACLS, stuff like that. Don't get excited throughout this because that's where you're going to make mistakes. Calm, collected. Keep your cool. It's very important in providing the best care you can, especially in an emergent situation. And it can be tough, but also getting control of an emergent situation when everybody else is frantic is sometimes a little difficult. I've stopped a code before and said, everybody stop what they're doing and freeze and take a deep breath because it was such chaos.
Yeah.
And I said, okay, now let's restart and let's communicate. And things go smoother when you can do that.
Sure.
It's very frustrating to not be getting anything done because everybody's so frantic.
My brain doesn't work. I mean, if the adrenaline takes over, I'm not thinking. And we need to be thinking all the time.
Right. I don't know what we've done, what we're supposed to do. Nobody could, I don't think. And it's just, we've got to keep the ultimate goal in sight, and then us trying to do the best we can. But that's very much clouded when there's chaos. And that's not just a code situation. That could be anything that you can do.
Compassion fatigue. Is that something you have feelings about, have thoughts about?
I have very strong feelings about that. I think it's very easy for anybody, even your number one Daisy awarded top-notch nurse or paramedic or whatever you may be. We get tired. We get emotional. We get personal things in our lives that we can't just shake off. And it makes our compassion die down a little bit. Some people are able to really wrangle that in and realize it and do what they need to do to still be compassionate. But it does get very tiring sometimes to keep that smile on your face when people are not making you smile. And that's sometimes you just need to step back and take a moment. If that's appropriate, that's appropriate. It's fine. I don't encourage anyone to take abuse in any shape, form, or fashion. I do want to be very clear. That's one thing that I'm very adamant about and become quite passionate about is we get abuse to some degree in healthcare, whether we like it or not, but there's definitely hard cutoffs for that. You're not going to scream and cuss at me. You're definitely not going to lay your hands on me, whether you're a patient, family member, whatever, or a coworker. You're not going to talk to me that way, and I'm not going to talk to you that way. So I think laying those boundaries is a very good, healthy thing to do. And if the other individual, whoever they are, is not responding to those boundaries, then you need to just remove yourself from the situation. Don't escalate it. I can tell you right now, It's not going to end in your favor no matter what you do. You can't win that battle. It's just going to ultimately backfire on you, whether you're wrong or not. So compassion is something that can come very easily in some situations, and then others, you find your human nature taking over. This person deserves to be laying here like this. They're a child molester and all this XYZ, but everybody still has basic rights, no matter what kind of human they are still a human. So just remember, one day we're all probably going to be laying in a bed, or we're going to be on the side of the road needing the ambulance. You don't want to be treated subhuman yourself, so don't treat people that way. Golden rule.
You just have to take care of everybody. Like, that's the job.
Right.
One time, a paramedic preceptor that I was riding with, we picked somebody up at the jail. And I don't know anything about the person, the guy. I assume she didn't either. But I was going to start an IV on the guy. I was a student. She said, if you get this on the first attempt, you fail. As in, you need to stick this guy multiple times because he's a prisoner. And I didn't. I got it on the first try. But I was like, that made me think so much less of that person.
Right. I don't want to be thought of as that type of person. I feel like I've been that person probably a few times in my career. I think we probably all have.
Yep.
3 a.m. when you was sleeping so good, but because you're exhausted, and this drunk's trying to fight you. The compassion is not at its peak.
The same drunk you've already fought 3 times the same night?
Absolutely. It's hard to find the compassion at that point. But if you can't find the compassion, at least don't be cruel. I mean, I guess that would be the next type of advice in that situation. But yeah, just to kind of play off what you said, a lot of times we'll have inmates that are admitted as patients. And I make it a point to not learn why they're incarcerated.
Yeah.
I don't want to know. It could be something ridiculous that they shouldn't even be incarcerated for, or it could be horrific. I don't want that to cloud my care for the person. And I would venture to say the majority of the time, they are the best patients. Now, dealing with the guards is a different story. They're the ones that absolutely do not understand compassion. I have been nose to nose with some guards over a patient before, because one thing I will do is advocate. I think that's probably the most important thing as a provider we can do is advocate for our patients. And I will do it to the point of getting myself in trouble, and have. I'm not ashamed of that in the least. But a guard's not giving them basic human rights, I'm going to probably lose it on the guard. I had to make a few phone calls to the warden before, but everything's worked out usually in the end.
I feel like you can never go wrong at advocating for the patient, the person you're caring for.
Absolutely not.
You want to talk about some specific things that play a role or maybe help in coping with death and dying, like humor or religion or spirituality?
I think that's all individual. You find religion or spirituality, whatever your path is, that works for you. And then some of us, like myself, find humor to be the ultimate out. But once again, read the room. If you're with a person, a coworker that's highly religious and stuff, maybe that off-putting humor is not the way to go. So find that same messed up coworker like yourself if you're going to be dark humoring, because you're probably not going to get appreciated for that humor. It's probably not going to help you out when you are reported for it and stuff. So find what works for you, but also know when it's appropriate to do so. And just make sure whatever it is healthy, because, a lot of people have went down the wrong routes with that. Drugs, alcohol, things of the such stand out as top, the top non-healthy, but there's many others that are not healthy that wouldn't be so obvious as that. It's an individual journey for all of us. We just got to figure out what works for us.
We had a former coworker, Frankie Thaxton. He was the best person I've ever been around at reading the room. That man could get away with saying stuff that I would have gotten fired for, I'm sure, but he just knew when he could get away with it. I don't know how.
I agree. Know him well too. Yeah, to have that knowledge of how to read the room so well, maybe one day.
When we were communicating back and forth about doing this, there was a quote from something you wrote that I thought was just phenomenal. You wrote, "Death is death. Dying is another issue. Trying to be there in someone's final moments is tough." Can you just elaborate on that? I just love that.
Just to start kind of, I guess, with defining it, death is death. It's the cessation of life. Nothing's working in the body anymore. That's pretty much game over, there's nothing else to talk about with that. Dying is a totally different aspect. This could be short term, long term. It could be brutal. It could be painless. We also can get into the, end of life care, hospice. Sometimes, unfortunately, people decline to where they can't even make it to hospice, and we have to do sort of a comfort care, hospice in place situation. So you are there for those final moments for them. And prioritizing the patient and the family in that moments is very important. Nobody on this planet wants to die without dignity, but dignity can be kind of hard to find when you're at this point. So doing everything you can to preserve that, I think, is very important. Keeping them comfortable. And then 2 things you don't forget is, making sure the family's taken care of equally as well. Make sure you're taking care of yourself too, because this is affecting you whether you're realizing it at the time or not. You can't just sit here and watch someone die without feeling something. If you can, then you're a sociopath, we got a different issue going on. But it's okay to feel things. During COVID, I had a patient that had been on BiPAP probably for about a week. I think we had him on a Precedex drip to help, just if I'm remembering correctly. Got to know the family very well. Very nice people. Always at the bedside with him. After, I guess, about a week and a half or so, it became very clear he was not going to recover. They did not want any further escalations and finally came to the decision of just withdrawing care. So physician educated them, everything, we're going to take everything away and he will die. There's no ifs, ands, or buts. They understood. So we got some medications to kind of make it more of a peaceful thing and sitting at bedside with them and removed the BiPAP, and we made it maybe 10 minutes, which if you've ever been in this situation is pretty quick, and thankfully so. But I just remember the daughter asked her husband to put on music, and he put on I Can Only Imagine.
Oh.
And to this day, when I hear that song, I just get chill bumps. I sat there and cried with them, and eventually he passed, and they walked out to the family area to do their thing, and I was walking down the hall to get some supplies to start, doing the care, cleaning him up, and a tech, one of the super techs that everybody wants around, would prefer it over a nurse.
Yep.
Called me in the hall and said, "Are you okay?" I said, "No." And I think that was the first time in my career I'd actually come to terms and being open about, I'm not okay. But that was a relief, though, to be able to just come to terms with, I'm not okay. So I need to do what I need to be okay. But being able to get this man cleaned up and get him presentable for the family. Remember the Crimson Tide blanket that he loved, covered him up with that, made him presentable for them to come in and just, have their moments with him. That was closure for me. So just listen to what your emotions are telling you, because they're not there for no reason. They're nagging at you for a purpose. And sometimes you got to listen really hard. And that's not easy during a busy day or when you're got 100 different things going on in your mind, but sometimes you got to stop what you're doing, even if it's for 5 minutes or so, and just listen or feel, and that's okay.
Yeah, that's a hugely important time where you can really make a difference, like you're saying, just by doing little small things. I don't know that that's something we're ever trained for,
No.
Yeah.
Not at all. No textbook in any health care program in the world includes how to deal with these situations, which is a shame.
Yeah, agreed. Because that's definitely something people are going to remember. You don't know which cup of water or which pillow somebody's going to remember, but the moments when somebody's dying, somebody's going to remember that, even if it's just us.
Yeah. And we don't always know the right words to say, but sometimes trying to say something, or maybe reading the room once again, not saying anything at all, just being present is enough for them. Whatever you can do to be important at that point, even though if it seems silly to you, it could make all the difference.
Yeah, working in the peds ICU, I guess, again, is where I really had some experience with all this. And I've gotten pulled into the prayer circle, standing around the bed, holding hands with everybody. Not in my wheelhouse at all, or like you said, sometimes you would think if you withdraw all the care, they're going to immediately die. But sometimes they do not.
Oh, no.
Sometimes it's hours or days, and the death watch is horrible.
Mm-hmm.
I remember having to wake a little girl's family up one night. It was one of those where we thought it was going to be quick, but it was not at all. So like some of the people had gone home, like we were just kind of in a holding pattern. The mom was still there and she was asleep. And just, I saw a change on the monitor and I knew that we were finally there. And I'm like, How the hell do you wake a child's mother up and tell them that they're about to die? I don't know. I don't have the words for that. I don't know what to say.
I don't think anybody truly does. And I'd love to be the imparter of priceless wisdom, in this, but in that situation, there is no right words, but you have to do something. You have to say something, and we'll call it what it is. It sucks. I mean, it does. It's hard, but that's what we do. And that's why this isn't for everybody. And hell, sometimes I wonder if it's for me.
Yeah, maybe it's not for me.
Yeah. I mean, it's okay to second guess yourself sometimes. Don't get me wrong. I've quit many days just to clock back in the next day. But, this is tough sometimes. And there's no right or wrong way to do things sometimes. And I think what makes that the most difficult is when there's no right way to do something. So what do you do? And I think we just have to figure it out.
Yeah, I guess that's what it comes down to.
Yeah, it's tough.
Any other specific advice or examples about how to be there or things you can do during those last moments, final moments?
We kind of mentioned earlier, you come into this fresh, your guns blazing, thinking you're going to save the world. And we're not. But we always want to do something. And sometimes we can't, and then we feel helpless. And that's not always the case. We didn't give this person cancer to say. We didn't. But sometimes we can't help it either. And people have the right to die. That's one thing that has been so hard for me to get a hold of. They have the right to choose to die. Back to another story, a patient I'd taken care of kind of off and on for well over a year was finally declining to the point it was obvious. The wife was just not coming to terms with it, or at least not to the point of decisions. And he was starting to get to where he was not going to be able part of the decision-making process. And that's getting very dangerous ethically in our scope as a nurse to be able to say, you can't say this is what you need to do because that's their decision. But she caught me in the hall and she asked me, what do I do? I said, I can't tell you what to do, unfortunately. She said, okay, medically answer the question then. Because I think she was reading the room herself. I said, okay, medically, he's had a rapid increase in oxygen demands over the last 12 hours. His mental status is starting to decline. So this is very ominous signs. I said, I think you need to have a discussion with him while he has, still has his mental status with him. And that was enough to make her understand, I've got to have this talk. We've got to come to a decision before I don't have the chance anymore. And it turned out to be the perfect storm situation. Our palliative care nurse and the hospice representative met in the hallway, went and talked with him at the same time. They was able to get him in an inpatient hospice facility that was just right down the road that same night, and he passed that night. But I remember, these people were very close. And of course, we're in a immunosuppressed unit. We wear masks at all times around the patients. Over a year, God never seen my face. As much as I'd taken care of him, never seen my face. And I was leaving for the day and knew I'd never see him again. All the family was in the room. It was an emotionally high state. They're all hugging me, saying goodbye. And I stopped on the way out, and he was kind of just in and out at that moment, but we had him comfortable. And I stopped, and I said his name, and he was able to just, kind of open his eyes and look at me. I said, I just realized you'd never seen my face, buddy. I said, and it don't matter anymore. So I pulled my mask down and just smiled at him. I said, go to your grave with that, bud.
Oh.
And he giggled. And I was like, nope, that's what I need. That's my closure. And I left. Because he was very much the person that you knew that kind of dry humor would work with. And I knew that would give him closure too. But needless to say, I lost it, after I left that night. Trying not to right now, just thinking about it. But this can be tough at times. But the helpless feeling that we go through can be even tougher. But it's okay for people to die. We're all going to. Strangely enough, the most natural thing in life is death.
Yep.
We do what we can to prevent it, but it's still inevitable.
Are you familiar with Dr. Monica Murphy? She wrote a book called It's Okay to Die. She was an ER doctor around here for a long time. And
I've heard of it. I have not read it.
Yeah, I haven't read it either, but I want to.
Yeah. And it is. It is okay to die. And we've got to respect that. And sometimes cultural or beliefs can play into that.
Yeah.
I know we've had to tell people we can't treat them because they're Jehovah's Witness. They won't accept blood products. Well, I'm very sorry. We didn't give you cancer. That's not our fault. But if we begin to treat you and you won't accept transfusions, we will be actively killing you.
Yeah.
So we can't. That's tough too, but you've got to respect their decision. And it's a weird feeling for them to say, okay, and accept their fate when we possibly could cure them. Never fully know, but had to have a pretty decent shot, but they just accept their fate and go about their way because of their beliefs. But, respect that.
How do you feel about assisted suicide, physician-assisted suicide?
Ooh, we're getting into a nice gray area here, huh?
Real gray.
Yeah. So, I would say that some of end-of-life care is still very controversial. It's a proven fact that, like, morphine relieves air hunger and things like that. But, in comfort care, we're kind of just pumping them. Is that euthanasia? Is it not? Leave everybody to decide that on their own. Physician-assisted euthanasia, though, that's such a gray area right now. First do no harm. That's, of course, the biggest argument in that. You're killing someone, you're harming them, but if you're making it a comfortable death when they otherwise were going to go home and blow their brains out or hang themselves or overdose anyway.
Or suffer for years.
Yeah. Are you actually doing them more good?
Right.
Those are muddy waters. I don't know how much I want to tread in them, but as the years go by, our country is going to probably, or even our world in healthcare is going to face a lot of controversial topics. And I don't know that there's any right or wrong to any of them. I do feel very strongly that healthcare in general would be a lot better if the government would stay the hell out of it.
And insurance companies.
You beat me to it. I was trying to think of how to nicely say that, but I don't think there is a way. I'm getting very sick and tired of insurance companies dictating people's care.
Amen.
Your healthcare provider has said this is the best course of action, and an insurance company has the right to say no. Are you kidding me? What kind of world are we living in? Finances should never be prominent over someone's, health, over their care.
Yeah.
But we live in a world where they are.
Or at least a country where they are.
Yeah, it's definitely country. And I'm sure you've seen this too. Beginning of the year, we're new deductibles, new plans, new copays, everything else, and now everybody's starting over for the year, and it's a constant battle.
Yep, we've been changing medicines left and right the past few days because insurance companies changed what they're going to cover. Yep,
and that's insane to me.
Yep.
If your provider has determined this is going to work best for you, that you pay for that insurance, they should pay for you. But until somebody can make it a change, and I don't even know who that would be. That's what we live with.
Yeah, and I have conflicting feelings because, like you said, government out sounds like a good idea, but to me, single payer also sounds like a good idea. So
True.
I don't know.
Yeah.
I don't know what the answer. I know this ain't it. I don't know what the answer is. I know this ain't it.
Yeah, where we're at's not there, but I'm with you. I don't know the right answer.
Have you ever been in a situation where somebody's death was not handled well or things did not go well?
Oh, I would say multiple times. Even just delivering the news, sometimes to family, I've seen it done very, very poorly. To be fair, that's never anything that's easy or anything that there's necessarily a right way to do, depending on who the person is, because everybody's going to, grieve their own way. But, walking out to a family of a teenager that you've been working on and saying, we couldn't do nothing, they're dead, and just walking away. No, that's not okay, and I've seen that. I do think that it's very important in delivering news like that to not try to sugarcoat things, using terms like they've passed on, they didn't make it, etc. No, I think dead is a perfectly acceptable way of giving that news, but with compassion and explanation. They were in cardiac arrest. We gave all these medicines trying to restart their heart. We ventilated them through this tube in their throat and shocked them. Whatever. All of our efforts, despite working very hard, were not successful, and we were not able to bring them back, and they died, and I'm very sorry. And that's still devastating news, but at least it's not cold and heartless. I don't know if it's still on the PALS video when you take your class, but there was a video of a child's death where they presented a case of the right way to do it and the absolute wrong way to do it.
Okay.
If you've not seen that, that is an emotional video to watch because the actors did a very good job. I think it did a very good job of portraying, most importantly, the absolute wrong way of doing it. They were very distracted. The family was asking questions. And like, I got to go see this other person. But no, they didn't make it. I'm sorry. No, we don't do that. We need to prioritize, their emotions and their feelings and understand that the grief is going to present different with every single person. The 5 stages are not a cut and dry thing. I've seen people go through all 5 stages of grief within minutes. And then some people linger in a stage for extended periods of time, typically the depression. And some people skip stages altogether. But I'm sure you'll give devastating news to some family sometimes, and they're just stone-faced. And, okay. And I don't think it really sets in till later. And then you have the right opposite reaction sometimes where they trash the room, One thing stands out, and I won't call even the physician's name, but years ago brought in an overdosed teenager to the hospital and worked very hard for a very long time to revive her and was unsuccessful. And the family was coming down the hall right after they called it. And the physician tried to catch the father and say, come out to the room and talk to me. He said, no, I want to see her. You can talk to me later. I want to see her. He said, we've not cleaned up anything. It's pretty gruesome in there. He said, I don't care. I want to see her. And the physician stopped and said, okay, that's your choice. And I thought that was the absolute right thing to do. And acknowledging what was the right thing to do at the moment, where a lot of people will try to force them away from that situation. It's not always right. Some people's closure comes from just seeing them. And, we're now trying to actively involve families in, a resuscitation process. And I think that that's a great idea if they're comfortable in doing so, because some people get that closure in physically seeing that everything was done, not just hearing that it was done.
Sure.
Now, some people can't bear to watch something so brutal as that, and that's okay too. But I think if they want to be a part of it, and of course, they're not interfering with care, then we should allow them to be.
Yeah, I agree. I like the idea of that. Because I think our instinct probably is get out.
Yeah, get out.
You go away. We're going to do this.
And I feel like it's a little bit of a protective mechanism because we know how gruesome that can be at times. But, it's their choice.
Yeah.
It's ultimately their choice. As long as you're not interfering with what we're doing, and I'm sorry, crying and wailing is not interfering with what we're doing.
Yeah.
If you're over there trying to pull us off them or, crawling all over the place, yeah, that's interfering. We need to get you out. But leave them there because maybe that's what they need to see. We did try. We did work hard. Nothing worked. And that's how they get their closure out of it. So it's a case-by-case basis, of course.
Read the room.
Yeah, read the room.
Yep. And maybe that's a protective mechanism for us, too, because, I mean, it's harder to keep it together if someone else is losing it.
That's actually, I guess, what I meant, but I don't think I realized I meant it that way till you said it. It is. I feel like it is more protecting of us and not even taking into consideration of what they would want.
I can't handle you being in there.
No, we need to tough it up and do our job. Yeah. And if they want to be a part of it, that's fine.
I like the idea of that. I don't know that I've ever coded somebody in a facility with the family watching. It's unavoidable in the field, of course.
Of course, yeah.
But I don't recall ever being in a situation where we're like, hey, you should go get the family because we're about to do CPR. I don't know.
I would say most of the time they don't want to be a part of it, and that's fine. We'll usually send someone with them to stay with them during that time and then tell them everything that was done and all that. But I feel perfectly comfortable if they would want to stay and have someone there explaining to them. I think that's the key. Don't just stick them over in a corner and let them watch what's going on. That's probably more traumatic than being out of the room. Okay, so right now we're compressing their chest because their heart's not beating. This medicine's supposed to help. things of that nature. That would be very helpful to them. But again, read the room.
Have you felt like you've gotten adequate or any support from the organizations you work for, supervisors, coworkers, as far as just dealing with this stuff day to day?
In a nutshell, no, absolutely not. I mean, there's been lots of times that, you've got that amazing coworker or even manager, whatever, that is there checking on you, making sure you're okay, will talk with you. But basically, the mindset in healthcare is on to the next thing, no matter what happens. And I feel like, at least at my facility, or even more specifically, the floor I work, we're getting away from that mindset.
Good.
You need a minute, you take a minute. And I think that is such a wonderful thing. I remember a nurse was just having a rough time with one of our patients that wasn't doing well. And we have a very strict controlled substance policy at our facility. So if you pull one, even a gabapentin, let's not get into that, but you have 30 minutes to administer it, or, you're getting dinged on it. And he pulled the medicine, realized he couldn't go in the room, and said, I gotta take a few.
Mm-hmm.
I said, sit it in front of me, I'll watch it.
Yeah.
And let the manager know it was over 30 minutes, and this is why. It was supported on that. Not an issue. So look out for each other. I'm so tired of the nurses eating their young kind of concept. And it's not just these, 30 years nurses trying to devour the new nurses anymore. It's just all over. Work as a team. We're all doing the same thing. We're all going through the same stuff. Today, my day may be extremely chill just because of the way it fell. And you may be just having a shit day. You cannot catch up for nothing. Let's help each other. Because if I'm just sitting here scrolling through Facebook and you're getting your butt kicked, I need to help you out. And I think we have come to that mindset where I'm at, and that's why I'm happy where I'm at. But I definitely know for a fact it's not like that everywhere. People will throw each other under the bus, and it's not okay. That's why burnout is so strong. It's not even necessarily just the traumatic events we deal with. It's just the mental overload of dealing with the stress. And some of it isn't even horrific health conditions or anything else. It's the fact of, I've got so many tasks to do. I'm 2 hours behind. I can't deal with this anymore. And no one's willing to help me. And I hate to hear those words. We should be able to help each other. And that goes as far as from tasks, meta passes, as to just being there to listen, or even recognize, hey, do you just need a few minutes? I'll watch your people for you. Let's take care of each other. We got to get back into that mindset. Or you think we're short healthcare staff now, give it 5 years. It's going to get worse if we don't take care of each other.
Yeah, I was thinking when you said that about the 30-year nurse, you have to look pretty hard to find any 30-year nurses these days.
That is very true.
Yeah.
I mean, the turnover is a lot higher than I ever even realized until I got back to looking at it. And when you notice that the turnover is really high, even on really great places to work, we've got bigger problems going on.
A lot of times when I have, usually it's patients who are also nurses. I'll say, oh, where are you working? Blah, blah, blah. How long have you been there? Oh, I've been there 6 months or a year. I'm like, oh, you must be in charge by now.
Yeah.
And initially I said it as a joke, but a lot of them will say, oh, yeah. Uh-huh.
Yeah.
Like, you're the veteran now. You've been there 6 months.
Right.
It's crazy.
That's scary to a certain extent. I mean,
Yes.
It really is. You've got babies leading babies. And I'm not saying, experience is everything or anything like that. I mean, yes, of course it does play into it.
It's a lot.
But I've seen those 30-year nurses that's got all this experience that isn't no more of a leader. The new grad would be a better leader than this person.
Yeah.
Just because you have the knowledge doesn't make you a leader. And that's another topic all in itself there too. Being a leader doesn't always mean being in charge either.
Amen.
I love one of the things, set the temperature is what we've said. The positivity, even when you don't feel like being positive, is contagious. If you're being positive, this other person's going to be positive. It's going to spread. You set that temperature for the floor or for whatever scenario, it's going to work. And the twist of that, if you come in negative and you set that temperature, it's going to be a really bad day for everybody. So you got that person that's being difficult, that coworker that's being just insufferable to work around, make them the outlier. they'll adapt or they'll move on. It's a good way to weed people out.
Love that.
Yeah.
Going back to the question about feeling supported by agencies, coworkers, whatever. This is a shitty leading question. Maybe you don't have to answer it, but do you think being a male nurse makes any difference in how you're treated in those situations?
Yeah, I do. I think being a male nurse can be challenging at times all the way around. I'm the person that cannot stand having to ask somebody to do my job for me, but there are definitely some females out there that are not comfortable with a male doing something a little more private or something like that. And I've had to divvy those out to females before. And I cringe about it, but I do want to give respect and dignity to people. And I will say, none of the females have ever minded that. And then you got the flip side of it. You've got some people that are very sexist and will treat females horribly. And even family members won't respect them. But when a male walks in the room, they straighten up. I don't like that either, because I am not a better nurse than this female nurse at all. I know the exact same things they do. Just because my gender doesn't mean anything. But to those people it does. So maybe you have to adjust things about it. But I think as a whole, the whole manly persona is perceived. So I think we're just expected to take things better than females. And that's not true at all.
Right.
No, just because I'm a man doesn't give me this burly, rough exterior where I don't feel things. No, it's not true at all. Yeah. I still feel things. I still deserve to be supported and be treated as a person that feels emotions. Currently where I'm at, no, I don't feel like that's an issue. I feel like I'm very well supported. Have I worked much worse places where I'm not supported in any shape, form, or fashion? I most certainly have, which was why I no longer work there. Some people will stay in those toxic environments, and I just encourage, get out. There's other places to be. Before you sit there and put yourself through that, go work at a fast food place. I mean, sure. Seriously, don't do it to yourself.
I've pretty much never felt really supported by an organization. As far as you just ran a bad call, are you okay? You just had to deal with this, are you okay? Never. It's always, hey, are you back in service yet? You know?
Exactly.
Can you take another patient now? Which is pitiful.
Yeah. It's like, hurry up, decon in your truck. You got to go on the next call.
Yep.
Okay, yeah, the truck needs to be clean, but I need a minute. This was horrible.
Yeah.
But nobody cares about that. It's just numbers.
Or people might care in theory, but when it comes down to we have to have a truck to run this call or a nurse to take this admission.
Yeah.
Yeah.
It's brutal. But if we all try to help each other, it might take a little bit off that. But we can't control the environment or not fully control it.
But I wish organizations, institutions would pay more attention. There could be some mechanism in place for.
Oh yeah.
Maybe we have a counselor in the hospital 24 hours a day for the employees. They could do something.
Yeah, automatic debriefings for situations should be mandatory.
Yes, agree.
And they're not. I've seen it a lot where it is provided for you and optional, but then I've seen times they don't even offer it. At least offer something to take care of your people. Because guess what? If you don't, they're not going to be your people for very long. They're going to go somewhere where they are supported. That's the best retention strategy on the planet, is to support your people. And nowhere in the world has caught on to that yet.
Right.
It's amazing. It's most simple concept, and they don't get it.
Yep.
Whatever. Throw more money at them. I don't care about that. If I'm miserable, the money don't matter.
Sure. We do want the money. We
do want the money, granted, but, I'm not selling my soul to the devil either. So if you really want people to stay around, pay them right, of course, but treat them right. That's the most common kindergarten theory in the world, mindset. And
yeah.
People that just look at dollar signs and numbers can't figure it out still.
Yeah, and if I have to choose between a quarter an hour raise or feeling supported and cared for by my company, I would take being cared for.
Yeah. You can keep your quarter for my sanity. Absolutely.
Yep. You want to talk about advanced directives, DNRs, living wills? I've been making more of an effort to ask my patients about that. Can you talk about how important that is, or what your feelings are about that?
I've had different feelings over that in the last few years as I've seen things. I encourage everybody to have advanced directives in place. I don't care if you're 18 years old in perfect health. anything in the world could happen. You want to be prepared in case something happens. And when it does happen, it's not time to be figuring it out. So sitting down, filling out advance directives or living wills, things like that, it's not you signing your death note. It is just preparing for things and getting things in line. It's taking care of everybody else when you're not there to care about it anymore. Because, I'm dead and gone. I don't really care what happens with my money or if anything happens, but it's going to fall on the people I love. And definitely don't want them to be sitting there trying to figure out the details. So everybody, despite your health, age, whatever your situation is, it takes 5 minutes to fill out a living will. Don't even have to have it notarized. You can have a second witness. Just get it done. Have it on file. It's going to save a world of hurt. And you can also change it anytime you feel like it if you change your mind. So it's not like you just signed it, in stone, in blood. It can be changed when you feel it's appropriate. And I've seen too many times that it's this weird situation. The person caring for someone the most is not their spouse. So legally, they're not their next of kin. And then the kids that they haven't seen in 15 years want to now all of a sudden step in and make decisions. And an advance directive would have fixed that situation very quickly. Power of attorney, whatever is appropriate for you, especially if you do get this life-ending diagnosis or something along those lines. You don't want those greedy family members that are just out for money making decisions about your health care.
Amen.
Because I got a feeling I know which direction they're going to go, and it's not going to be in your favor. So have all that stuff lined up ahead of time.
Yeah.
And it's not facing your mortality. It's just facing the facts of
reality. The reality of mortality.
Yes. I guess in a way it is facing your mortality because you are immortal. None of us are going to make it to 300 years old. At least I sure hope I don't. I'm 40 and feel broken in every way at this point, I don't want to live no longer than, my body's going to put up with it.
Yeah.
But we're all going to die. Let's be ready for it when it happens.
And I hope people know that it is pretty easy to do that stuff. You can just Google it. You can print out all the forms for free, sign them, get them witness notarized. The AARP website has the advance directive forms broken down by state. That's a good, reputable place that you can go to and get the form and just print it and get it done.
Very simple. A lot more simple than what I guess I realized before I was dealing with it a little bit more, But I think it's very important that everybody gets that taken care of.
I just started asking about that as part of the annual physical, like just a few months ago, I guess. Obviously, if you ask a 30-year-old if they have an advance directive, they're probably going to say no. But I've been surprised at how many of the elderly people who have pretty chronic health conditions don't have that stuff done. I want to be like, what are you thinking?
Right. And then you find yourself as a end-stage COPD, bilateral amputee, add it all up in the hospital. And now we've got to put you on a ventilator because you didn't have things in line.
Mm-hmm.
That's where it feels like we run into an ethical issue of what are we doing?
Yeah. Is this harm or is it not?
Yeah, for real.
Back to that.
We are harming you because there's no chance of your survival, but you're not able to tell us, don't do that.
I'm sure we've all been in the position of having to code the skeleton.
Yes.
Obviously been wasting for years and somebody just is not ready. There's nothing in place.
Yeah. If you're doing compressions on somebody and you feel like you're touching their spine, then it's probably time to think about maybe we shouldn't be doing this.
Ugh, that's the worst.
Yeah. Maybe that's an extreme example, but it really isn't. It's the sad thing.
We've been there. Yeah. It happens. Ugh. I feel like we've covered this topic. What else would you like to say? You have the floor. What didn't I ask you about that I should have asked you, or what else? What else did you have in mind?
No, I feel like we have covered it pretty well. I think it all sums up to keep your compassion, keep your mental health in check, and you're going to do the best you can in all this. But if you ignore those, you're not going to be okay, and the people you take care of are not going to be okay. So take care of yourself, take care of each other, and take care of the people you're taking care of, and then everything's going to fall into place. It's okay to feel the emotions. It's okay to question things. It's okay to do anything other than what it's not okay to do. I guess that's the best way to put it. But the most important thing is you're no good for anybody if you're not good for yourself at the moment. So Keep yourself in check more than you do anything else. And it'll all kind of flow from there. Nothing can make horrendous situations any easier, and we can't avoid them, unfortunately. But responding to things instead of reacting is going to help you survive this yourself. And I can say that all day long, but actually putting it into practice is not quite as easy. So keyword there is practice. Start practicing it when the things aren't so bad. And it's going to be a little bit easier to do when it is bad. And I think that's what has helped me the most. Maybe I'm not having just such a horrible day, but I still take 5 minutes to decompress and just kind of recenter myself. Then it becomes a little more muscle memory to do it when things are getting really stressful or really rough.
Love that. Beautiful advice. Well, I think that's a good place to leave it. Justin Gallien, thanks so much for being on the podcast. I really enjoyed this conversation. I appreciate it.
I have to. Thank you, Jody.
Come back anytime.
I definitely will.
All right. Thank you again to my guest, Justin Gallien. I really appreciate him reaching out and letting me know this was something he was interested in and wanted to talk about so we could get that set up. If you have anything you'd be interested in talking about or anything you would like to hear me talk about, feel free to get in touch. Special thank you to our Patreon supporters. I'm recording this intro and outro on Super Bowl Sunday, so by the time it comes out, we'll either have a three-peat with the Chiefs or a new champ with the Eagles, so looking forward to see how that goes. I got my air fryer and my chicken wings ready to go for this evening, so I'm going to go enjoy the game. Hope everyone has a great week, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients, in that order. Sorry, I feel like I'm pulling us away from what you wanted to talk about. I apologize.
I had a feeling it would happen that way. That's fine.
Sorry, I strategically positioned the tissues over there behind you. I should have put them over here behind me.
Yeah. It's we may both need it. This is a difficult topic. So.
It is. It really is.